Welcome to nursing care of the child with an alteration in bowel elimination and gastrointestinal disorders. Now, to help you think about the information in this chapter, I wanted to bring you back to things that you learned in fundamentals about concepts related to elimination. Now, you know that the GI tract is mouth to anus, and there is a lot in between because there's your upper GI tract and there's your lower GI tract. And then there's also, if you will, in between there, what happens in the duodenum, jejunum, when you have the mesenteric artery feeding your gut, absorption of nutrients, and also the transport of elements that need to get, moved along and out the rectum. When you don't have some of those pieces in place, if they're missing, or if there's a disease process that is causing inflammation, or if there's an obstruction, or if there's weakness or loss of motility, right? The nerve innervation, all of these things are potentially what you would have to deal with when there's an alteration in bowel elimination or gastrointestinal disorder, GI disorder, okay? So let's think about going into chronic GI disorders now. Now we've dealt with acute ones, right? Which are going to be, come up suddenly and then they have to get dealt with. Okay. So some of them are emergent because you don't want certain sections of bowel to become ischemic. So surgery is going to be a part of it. And most of them actually, oral candidiasis thrush, you don't need surgery. Oral lesions, that we discussed, where some of them might have, due to, the herpes simplex virus, and, watching the ability to eat. Now we're going to be going into the chronic GI issues. And here you're looking at gastroesophageal reflux, peptic ulcer disease, constipation, encopresis, Hirschsprung disease, short bowel syndrome, inflammatory bowel disease. Is it Crohn's or ulcerative? Is it immunologic or inflammatory response? Celiac disease and functional abdominal pain. So, here we have, and then there's also, failure to thrive and chronic feeding problems. Now we have GER and peptic ulcer disease. GER is basically gastroesophageal reflux, right? Reflux of the stomach contents up into the esophagus and potentially as high up into the oropharynx. Now, this is normal for the most part. Remember, I told you spit up is normal. Some kind of gastric contents coming up is normal. However, when it becomes problematic, when it is frequently enough that the pH level of the gastric contents, the bile, the acid, and the pepsin, can in fact damage the esophagus. When that occurs, you might see esophagitis, you might see laryngitis, you might see esophageal erosion. You might also develop a pneumonia because remember the esophagus and the trachea are side by side, and so aspiration pneumonia might occur. So medically, you try with positioning, right? You try to have the child sort of sit upright for a while, 30 minutes, at least 30 minutes after eating. Maybe you have the child have smaller feedings and more frequently. And that is, after, if that doesn't work, then you're thinking about medications that might help to decrease acid production and stabilize the pH of the gastric contents. And if that doesn't work, well, then there is a surgical procedure. It's called a Nissen fundoplication, and that is basically performed for anti-reflux therapy. And that is where the gastric fundus, remember fundus is the upper portion of something. You can have the fundus of a uterus. In this case, it's the fundus of the stomach that gets wrapped around the lower segment of the esophagus, and that is to help, reduce potential, complications. So that's a different kind of pathology than peptic ulcer disease. Peptic ulcer disease is where you have H. pylori, which is an identified gram-negative organism that causes mucosal inflammation, and in some cases it can actually cause ulceration. Okay, so how is it that this gets treated? Well, you want to potentially give antibiotics if H. pylori is notified or is identified, rather. You might need a proton pump inhibitor. You might need histamine agonists. So if there is damage enough where there's esophageal or gastric hemorrhage, you're going to have to put an NG tube down to help decompress the stomach. So some of the reports of pain, right, are in the abdominal area. There might be GI bleeding, there might be vomiting, and abdominal pain is the most common complaint with kids with PUD. And you're going to have to manage, like, do an assessment on them, and they might have specific tests looking for H. pylori in this instance. And it might be that dietary management is what has to get taken care of or has to be discussed with parents. Now, constipation is very common. It's a very common problem amongst children. And, it also is ultimately defined as failure to achieve complete evacuation of the lower colon. Now, term newborns should pass meconium stool within the first 24 hours. And if they don't, then they are at risk for having an underlying GI disorder. So when you think about how often, when you ask about bowel habits, how often does a child go? It's going to vary by age. Okay, adults generally go once a day, once every 2 days, but really daily is what you're looking for. Bottle-fed babies produce stool 1 or 2 times per day, but they can go 2 to 3 days without a stool. And, breastfed infants can produce a stool with each feeding, although sometimes they'll skip a few days between stools. So the variety of it is very difficult to gauge as far as like correlating it to health. But functional constipation can occur in preschool age children, and it is defined by certain factors. Basically, in the span of 2 months, you're looking at less than 3 bowel movements weekly, at least 1 episode of fecal incontinence weekly, stool withholding behavior, hard or painful bowel movements, large fecal rectal mass, and stool passage of a volume that's enough to clog a toilet. Okay, so some of the causes of pediatric constipation are in this table, and encopresis is basically liquid stool that leaks around hard stool and out of the child's anus, so it's very difficult to control, and it's a source of great embarrassment for young people. Children may complain of pain, and they, parents might bring them in for tests. Look, my child is having pain, and so there might be abdominal x-rays. There might be, palpation of the abdomen. Additionally, there could be some checking for occult blood in the stool. So what's going to happen for these individuals is that once a determination of constipation exists and once a rule out of some sort of like neural or underlying other pathology exists, there's going to be teaching that occurs, right? You're going to have to educate the parents on how to assess for signs of constipation and withholding behaviors. Some kids don't want to go to the bathroom and have a bowel movement in school because it's an embarrassing thing. They want to wait till they come home. So that extra holding is not good. The longer stool stays in the large rectum, in the large intestines, the more it's going to dry out and it'll be difficult to pass. Helping family and child cope is going to be another key element. And part of the nursing end of constipation is basically administering enemas. Okay, there is a nursing procedure 42.2 in your book, which kind of describes what that process looks like. Hirschsprung disease, well, that is a movement disorder of the intestinal tract that then results in, obstruction. So within the first 24 hours, an infant should be passing meconium. And apparently Hirschsprung disease is the most common cause of neonatal intestinal obstruction. So what does it look like ultimately? Well, there's a ganglionic bowel. That means that there is no nerve innervation. So how is movement supposed to occur if there's nothing to signal that movement needs to occur? All right. So what's going to happen? Well, there's going to be an ostomy. Okay, there's going to be surgery, and there's going to be an ostomy that gets put into place. So short bowel syndrome is a syndrome of nutrient malabsorption and basically excessive loss of electrolytes, micronutrients, and macronutrients. And that is because large sections of bowel either don't exist or they've had to be taken out because different disease processes have basically resulted in that. Okay, so you're looking here at this picture of what's a normal bowel and then what happens with when you don't have enough bowel and what that malabsorption looks like. So what are the causes of it? Well, intestinal atresia, where there are parts of the intestines that don't connect. Um, there's gastroschisis. I showed you a picture of that before. That volvulus, which is that twisting of the bowel, which results in necrosis and death and loss, if you will, of functioning bowel segments. There might be a long segment of the Hirschsprung's disease, where there's no innervation, if you will, of neurosignals to help with movement. There might be meconium ileus, where a segment of really extra sticky meconium is stuck and it doesn't move and it thus needs to then be removed. All of these are factors as to what can result in short bowel syndrome. Now, what are some of the things that need to get done in order to help take care of it? Well, you want to use antibiotics to potentially control bacterial overgrowth. Remember, there's normal flora and fauna. And if it overgrows, well, then it needs to be taken care of, tempered down. Vitamin and mineral supplementation, antidiarrheals, such as, loperamide, as well as gastric acid suppressive medications, right, need to be given. Look at how much, it's short bowel, so there's not a lot of, we're going to have rapid movement, which is what would result in diarrhea. You might need TPN for this instance because how are you going to get those nutrients in? So TPN might be used for a very long period of time as procedures are worked on to help, with this resectioning, if you will. And honestly, a lot of these infants that are born, they have a lot of complications that result because TPN can also result in irreversible liver damage. So there might be progression to enteral feeding, but it's going to occur really, really, really slowly. Okay, it's a very devastating disease, short bowel syndrome. Then we have inflammatory bowel disease. And two of the major inflammatory bowel diseases in kids is Crohn's disease and ulcerative colitis. The causes are unknown. However, there's always research that is going on. Don't know if it's potentially a virus or bacterium or genetic, like an inflammatory response or a immunologic response. The features of the Crohn's disease and ulcerative colitis are listed in comparison chart 42.2 on page 1612. Crohn's disease versus ulcerative colitis, I have put this graphic here to help show that ulcerative colitis affects only the colon, and Crohn's disease can affect the entire, gastrointestinal tract, but in sections because it's discontinuous throughout the tract. Some of the signs and symptoms are, abdominal pain, nausea, vomiting. In Crohn's disease, you'll have weight loss as well. In ulcerative colitis, you're going to get rectal bleeding or bloody diarrhea. There's, fever. There's potentially delayed sexual development as well. Medications are really important in controlling inflammatory bowel disease. And so there are different kinds of meds that you're going to have to help teach. Everything from antibiotics to immunomodulators, anti-tumor necrosis. These are all in your book, but this is all part of the teaching that you're going to have to do. You're also going to have to help with family and child coping. It might be necessary to get special permission for bathroom, privileges in schools, for the school to understand what's going on with the child. Also, there might be a need for an ostomy because part of the GI tract has to be cut out, resected. And so living with that for a while might be an issue. Children tend to be of small stature due to the illness itself and steroid use. And so this can create psychological issues. So, there's much fear and anxiety that's related to, chronic diseases, and particularly this one. Celiac disease is an immune disease in which people can't eat gluten because it damages their small intestine. Look at this picture of healthy villi. See how they're little like finger-like projections? Nutrients are able to be absorbed appropriately in that healthy environment. In celiac disease, you'll notice that the nutrients cannot really be absorbed into, the inner linings of the GI tract, and thus many important nutrients are lost. Thus, malnutrition can occur. Some of the classic symptoms of children with celiac disease are having diarrhea or steatorrhea, which is fatty stools. Also, there's constipation, failure to thrive or weight loss, bloating, abdominal distension, poor muscle tone, irritability and listlessness, dental disorders, anemia, delayed onset of puberty or amenorrhea, and nutritional deficiencies. Typically, you might see a child with a distended abdomen and very wasted extremities. A child for the rest of their life basically needs to manage their celiac disease by strict adherence to a gluten-free diet for their entire life. Teaching Guidelines 42.3 basically has dietary considerations in a gluten-free diet, and it shows foods that are allowed and foods to avoid. And those are actually key concepts to understand when doing teaching with parents who might ask questions about what kind of foods, their children can eat. Functional abdominal pain basically is a very common GI complaint for children and adolescents, and unfortunately the etiology remains unclear. However, there is a group of specialists who are focusing on the identification, management, and treatment of both adults and children with functional GI disorders. Now, to me, it's kind of difficult to understand the difference between functional abdominal pain in children and irritable bowel syndrome. So there is a box here, which is 42.5, which should help with understanding how to discriminate between irritable bowel syndrome and functional abdominal pain. Functional abdominal pain is multifactorial, and there are issues resulting in problems from a gut-brain relationship, if you will. Symptoms can result from an alteration in the transmission of messages between the enteric nervous system and the central nervous system. And then also, when you think about it, neurotransmitters are found in both the brain and the gut. And so part of this is that there might be an inability for structural or functional movement of, intestinal motility, right? So autonomic nervous system controls the body's response to emotions and stress, and then there's intestinal motility, and these are two ways in which can result in functional abdominal pain. Let's look at hepatobiliary disorders. They include pancreatitis, gallbladder disease, jaundice, biliary atresia, hepatitis, cirrhosis and portal hypertension, as well as liver transplantation. In pancreatitis, Here you have an image of the pancreas and the gallbladder and the relationship to the stomach. And you can see the pancreatic duct. And what happens with chronic pancreatitis, because there are two types, there's chronic and acute. You can see that gallstones and calcifications, basically dilate the pancreatic duct, and thus an inflamed pancreas exists. Well, in an acute instance, where there is a complete blockage, if you will, of gallstones way up in the front end, right, not into the pancreatic duct, but right at the opening, well, then you can get an inflamed pancreas as well. Common causes of pancreatitis are abdominal trauma, drugs and alcohol, multi-system disease such as inflammatory bowel disease or systemic lupus, erythematosus, infections, right? Hepatitis, cytomegalovirus, potentially congenital anomalies like ductal or pancreatic malformations, obstructions, well, like gallstones and tumors in children, potentially, or also metabolic disorders. Now, chronic pancreatitis is defined based on the structural and or functional permanent changes that occur in the pancreas. Now, when the pancreas is inflamed, um, basically individuals are put on NPO status, like immediate bowel rest. An NG tube is placed for suction, and that helps to keep the stomach decompressed. And then there are routine labs that are ordered. Serum amylase in, checking to see when oral feeding can be restarted. So what does this kind of a patient look like? How do they present? Well, they'll present with persistent mid-epigastric and periumbilical abdominal pain, vomiting, especially after meals, fever. You must maybe check the child's current and past medical history for risk factors, because risk factors are cystic fibrosis, a history of gallstones, traumatic injury, family history of hereditary pancreatitis. Labs, well, you're looking at those common labs of serum amylase or lipase. You're looking at the liver profile, looking at the liver function tests, bilirubin. You're looking to see if there's leukocytosis, hyperglycemia or hypocalcemia, C-reactive protein levels. Diagnostic studies are basically going to be performed to identify cysts or malformations on the pancreas, and that might be through an abdominal x-ray, it might be through an ultrasound, or an endoscopic retrograde cholangiopancreatography, an ERCP. So nurses are going to help with NPO status and that NG tube being kept in place, giving fluids appropriately IV to keep the child hydrated. And, feedings might be started only after the serum amylase level has returned to normal. And surgery is indeed rare with children with pancreatitis, except where severe abdominal trauma or major ductal abnormalities occur. With cholelithiasis, you're looking at the presence of stones in the gallbladder. Now, cholesterol stones are usually associated with hyperlipidemia, pregnancy, obesity, birth control pill use, as well as cystic fibrosis. Now, cholecystitis is an inflammation of the gallbladder that is caused by chemical irritation due to the obstruction of bile flow from the gallbladder into the cystic ducts. If cholelithiasis results in symptomatic cholecystitis, then the gallbladder gets removed, which is cholecystectomy. Now, I have had gallbladder pain on and off since I was in my 20s, and I have always managed to ride through the pain. I've had the privilege of going to the ER, I think twice, and meeting with a surgeon who said they could blindly take out my gallbladder, but they couldn't guarantee that that would take away pain because they just couldn't be sure. So my way of managing it is that I have altered what I eat, and on occasion I'll still get some gallbladder colic, but if I'm able to ride through the pain, then I have not as yet found the need to have the gallbladder removed. The pain with gallstones is a little different. It's right upper quadrant pain, and it often radiates substernally to the right shoulder. Sometimes it comes around to the back like a vice. There's nausea and vomiting, a feelness of pressure in the upper abdominal area. Sometimes there's jaundice and fever. And if you were to palpate the abdomen, you'd find tenderness. And if cholecystitis is present, like the gallbladder being inflamed, well, then you're going to get very localized tenderness upon palpation. So what kind of tests are you going to be looking at? Well, liver function tests, bilirubin, C-reactive protein, CBC, amylase lipase, abdominal x-ray, ultrasound of the gallbladder. And, these are just common things that you're going to be using to help assess what's going on with a patient. Now, they might have surgery to have it removed, in which case then all of your surgical concerns pre and post-op and the teaching are going to be expected. Now, we also have biliary atresia. So to understand what that is, it's basically obstruction of bile ducts, okay? Bile ducts in the liver. And if those are blocked, well, then you end up with a result of the development of potential cirrhosis of the liver in infants. Now, because in biliary atresia there's an absence of some or all of the major biliary ducts, resulting in obstruction, what you're ultimately looking at is bile flow being blocked up, causes cholestasis, okay, and that results in jaundice and, very much a lot of complications with cirrhosis of the liver. So how does that get taken care of? What do nurses need to know? Well, in infants, there's a high suspicion of biliary atresia. If there is, the infant will undergo an exploratory laparotomy. And if that occurs, well, then there is a surgical procedure that is called a Kasai procedure, which is in your book. But so much what do nurses need to know? Well, if there's any kind of, surgical procedure, again, there's going to have to be teaching. You're going to have to look at post-op, adaptations. You might need to do NG tubes for feedings. Make sure that there are no infectious processes that potentially might be problematic. You might have ascites in the abdomen, so you might have to give diuretics. They might need to have fat-soluble vitamins on board. And, these are all some of the things to help with absorption of nutrients that you would consider. Labs would be serum bilirubin, alkaline phosphatase, liver enzymes, potentially needing an ultrasound to identify anomalies, liver biopsy to confirm diagnosis. Okay, well, some of this is going to be similar then when you think about hepatitis. Now, in your book, there is a table of hepatitis A, B, C, D, and E. Not only that, it goes into what the transmission routes are, what the incubation periods are, the signs and symptoms, and what the prognosis is. And what is hepatitis? It's an inflammation of the liver that is caused by a variety of agents. You can have anything from bacterial and viral infections to metabolic disorders, chemical toxicity, as well as trauma. Now, acute hepatitis is treated with rest, hydration, and nutrition. There might be the need to control bleeding as well. And ultimately, chronic hepatitis will require liver transplantation, in which case corticosteroids and immunosuppressants may be used for autoimmune hepatitis. Now, how else do you want to look at this? Well, how is a person going to present? Well, there's going to be jaundice and fever and fatigue and abdominal pain. So in order to figure out what kind of hepatitis you're looking at, you might want to look at other risk factors such as recent foreign travel, who they've been exposed to that's been sick already with that, medication use, abdominal trauma, sexual activity, IV drug use, blood product transfusion. All of those are issues that can potentially lead to hepatitis. So when you think about what hepatitis patients need, well, they also require rest, hydration, and nutrition. And if the child develops vomiting, dehydration, elevated bleeding times for their PT and PTT, or mental status changes, then hospitalization may be required. Let's look at cirrhosis and portal hypertension. Well, remember, cirrhosis of the liver, it happens as a result of the destructive process that occurs during liver damage, leading to the formation of nodules. Okay? These nodules distort the vasculature of the liver, and that leads to further complications. What are some of the causes of cirrhosis in children? Well, there is biliary malformations, antitrypsin deficiency, Wilson disease, galactosemia, tyrosinemia, chronic active hepatitis, and prolonged TPN use. Now, complications that can result due to cirrhosis includes the portal hypertension piece. And so in portal hypertension, the blood flow to, through, or from the liver meets resistance. And that's going to increase portal blood flow pressures. And that ultimately will result in collateral veins being formed between the portal and systemic venous circulations. And what can happen is that GI bleeding, portal hypertension can result in GI bleeding because the collateral circulation can shunt blood to the submucosal veins in the stomach and the esophagus. And esophageal varices are extremely dangerous. They're very difficult to see because if they rupture, then, it really is a mess. So the key is to prevent that from happening. So identification of this, happening in children is looking at what signs and symptoms are. And you're looking at nausea and vomiting, jaundice, weakness, swelling, and weight loss. So how do you find out if this is what they have? Liver biopsies and a potential upper endoscopy might show, those varices and bleeding. So this nursing management is very similar to that of the child with hepatitis. You're going to be looking at management of potential portal hypertension and bleeding varices. GI bleeding also, all of that must be controlled. And so you have to work to replace blood loss and also provide vasopressive therapy to constrict the shunted blood flow. Sadly, all efforts may end up in liver transplantation. And, ultimately you're going this route with hepatobiliary disorders that ultimately are going to result in the failure of the liver. And liver transplantation has become increasingly successful in kids in the last several years due to advances in immunosuppression. So when children are admitted to a transplant center for the pre-hospital workup, there's going to be a whole lot of anxiety because there's going to be a transplant of tissue, an organ, from one individual who has lost their life to an individual who may be just beginning theirs. What are some of the other considerations in, bowel elimination and GI disorders? Well, teaching, right? There's going to be teaching plans. If there's celiac disease, then you're teaching about a gluten-free diet or lactose-free diet. Nutrition's involved. You also want to catch them early, these GI disorders, to prevent them from progressing to an emergent situation. You've seen where some of them, if you don't catch them early, can result in ulcerations, can result in ischemic bowel or necrotic bowel, or in, rupture of an appendix, or thinking about vomiting and diarrhea, dehydration. This will be a big problem for young people. You need to restore the fluid volume and prevent progression to hypovolemia, which can lead to shock. So again, nurses need to teach parents, when it comes to constipation, to facilitate, daily bowel evacuation. And the child should sit on the toilet twice a day, right, for 5 to 15 minutes. You also don't want them to sitting much longer than that. So there's going to be a lot of teaching because you have to help these patients learn how to cope with what is going on with their individual issues. And what is that psychosocial impact? Well, it is huge. Some of it is devastating. Constipation can be a very stressful process because it might involve behavior modification. Short bowel syndrome is considered to be a medically fragile. The child is considered to be medically fragile for quite some time, and it takes a long time for that bowel resection to occur. And so children are in the hospital and dealing with complications potentially for quite some time. Now, some of the GI disorders require long-term hospitalization, and that means parents have to miss work and cut down on the time that they have to spend with other children. So there are a lot of issues that are involved, psychosocial issues involved with the care of, children who have some of these disorders. I hope this has been helpful because I want you to think about how the nurse is supposed to respond, what kind of teaching the nurse has to give to families, what are the kinds of meds based on symptom that get done, what are some of the tests that need to get done based on, where it is that you're examining and what it is that you need to be scanning for. Is it as simple as inspection, auscultation, palpation, percussion, or percussion palpation? Or do you need x-rays? Or do you need a scope to be done, like a colonoscopy or an endoscopy? All of these are going to have ramifications. And if there's surgery involved, then all of those surgical concerns of preventing complications need to be considered as well. Thank you so much for your time.